My name is John Drevik. I'm a PGY2 at Einstein Medical Center here in Philadelphia. It's our pleasure to have Dr. Serge Ginzburg, who's one of our urological oncologists here, to give a talk about transperineal biopsies today. So for that, I'll kick it over to you, Dr. Ginzburg.
Thank you, John. And I'd like to thank UCSF and the collaborative to help recognize the need for resident education even during these COVID crises. And I really appreciate the opportunity to give this lecture. I also want to really thank the residents for, being there on the front lines and taking care of patients during these crazy times. So thank you again. So today's talk is going to focus on transperineal prostate biopsy. It's quickly emerging and is quickly being adopted throughout the world. And it's really important to kind of get the details on this and see if we can disseminate that amongst our practices. So I have no disclosures. And today what I'm hoping to do is I'm hoping to cover evolution and adoption of transperineal prostate biopsy, perceptions about it, its functional outcomes and oncologic outcomes. We're going to discuss technical aspects of transperineal biopsy, including setup, positioning, analgesia, access options, as well as different templates that are out there. I'm going to show a short video, hopefully detailing some of the techniques, and there will be some time for questions as well. So let's get started. So to better understand the scope of this problem, this is kind of prostate cancer landscape, if you will. So about up to $19 billion are spent in US alone on prostate cancer care, 19 billion. So prostate cancer has a huge footprint in our healthcare system. About 30 million tests, PSA tests, are being performed as screening and surveillance and follow-up for prostate cancer. The number of prostate biopsies that take place across the United States, that number is a little bit hard to pin down, but numbers around 1 million a year are quoted in the literature. And approximately 190 men are diagnosed with prostate cancer annually, of which 33,000 die. So we're dealing with a big problem here, and our discussion is going to focus on this number right here, 1 million biopsies, and we'll see if we can improve our role in that number. So evolution of transperineal prostate biopsy. It has evolved. It has come, I'd say, full circle. So it started initially with open transperineal access, where we would cut down above the rectum towards the prostate and sample the prostate. That was somewhat invasive, and it then progressed to, developing a needle that would be able to travel transperineally, outside the rectum, towards an area that was felt suspicious on a digital rectal exam. So it's kind of finger-guided transperineal prostate biopsy, and that's the kind of the image that you see here on the left. Over time, it has evolved to a finger-guided transrectal approach with different safety mechanisms being developed, but ultimately it was still finger-guided until in 1970s and 1980s, the ultrasound technology was developed well enough to be able to image the prostate sufficiently. So it initially was used as an imaging modality, but then it was used for biopsy guidance. And again, that was transrectal ultrasound guided prostate biopsy. Until eventually we recognized the advantages of transperineal approach in staying out of the rectum and tracking the potentially infectious flora of the rectum into the prostate by maintaining transperineal access. And so ultimately where we are now is we're more and more increasing our transperineal approach, and we'll talk about details of that. So this is a paper by Filson and company, who basically, the purpose of this paper was to track MRI adoption and utilization across the urologic community. But in it, it also listed prevalence of transperineal prostate biopsy. And you could see that that's gray dotted line on the bottom. It's relatively flat and it's relatively low. And I kind of translated it into numbers here, but you could see that 0.5% of all biopsies across the United States, according to this MarketScan database, were done transperineally. So that's a very low proportion, okay? And that kind of sets the baseline of where we were starting around 2015. Now, they referenced this paper, and I thought it was an important one. They referenced it with respect to MRI adoption, but I think it applies to any technology dissemination in healthcare field or otherwise. And there are some certain drivers that kind of predispose technology to being rolled out and adopted. So firstly, it's the perception of the technology. Does it have a benefit that's important to us? Secondly, it's compatibility. Is it consistent with our values? Are we looking to decrease number of infections? Are we looking to provide better quality care? Is the technology simple? Okay, is it easy to adopt if we had to? And then is the trial of that technology available for us to kind of give it a go without committing to the technology? And then are there other people doing it that who we can observe and kind of gain confidence before we bring it into our practice? Additionally, you know, there are other important factors such as ability to communicate our results. Are there incentives for us to adopt this technology? And is our leadership supportive of this technology? Or are our funds limited, and can we not bring it into our practices? You know, this is kind of the curve that we see all the time with respect to dissemination of technology. There are innovators, there are early adopters, there's early majority, late majority, and laggards. So I think, you know, around the world, we're probably in the early adopters category, and we're racing fast towards the early majority, and hopefully this will come sooner rather than later. So again, this is back to Chris Filson's paper, and again, this demonstrates that adoption of transperineal prostate biopsy so far has been very low. But I think times are changing. So we participate in this in Pennsylvania Urologic Regional Collaborative, PERC, and in it we track our biopsy outcomes and biopsy number of biopsies, etc. And what I did is I kind of took some artistic license and I extended the timeline here, and what I did is I plotted our PERC numbers. So back in 2018, we're at 1.2% of all biopsies across the collaborative being done transperineally, and in 2019 that number rose to 2.9, and I can only imagine in 2020 that number will be yet higher. So again, I think the rollout is happening, and it's just a matter of time. So what are some of the perceived benefits and kind of limitations of transperineal prostate biopsy? So I think it's widely described that cancer detection rate appears to be on par or better than transrectal biopsy. You have access to anterior lesions, which are hard to reach through transrectal approach. You have better ability to sample the apex. You also, when sampling peripheral zone, get a full core traveling through the peripheral zone as opposed to just part of the core being in peripheral zone and the other part being in the transitional zone that may be compressing the peripheral zone. Infectious complications are clearly superior in the transperineal approach with sepsis rates approaching 0%. It's excellent. Antibiotic stewardship, as we'll discuss, many providers are omitting antibiotics during the time of biopsy. And so, you know, with quinolone resistance skyrocketing, I think this is really an important move. Rectal bleeding is non-existent, and bowel prep, sometimes, you know, to minimize infection, some people give betadine bowel preps, others give bowel preps to clean out, betadine enemas, and some people prefer patients clean out their bowel just for better visualization. But, you know, I don't know that that's really necessary. I certainly don't do that in my practice. As far as perceived limitations, it does require new equipment, or it may require new equipment. Ultrasound may stay the same if your manufacturer makes a different type of probe that's conducive to transperineal biopsy approach. And so there may not necessarily be a large investment that is required. Lithotomy positioning, we're all familiar with lithotomy positioning in the OR, but visualizing the prostate in lithotomy is a little bit new to us, but it's actually relatively easy and to me more intuitive. It is thought that stepper is required. Stepper is not required necessarily for transperineal biopsy, and template grid is used for mapping biopsies or sometimes freehand biopsies, but again, it's not required. With respect to new techniques, there is fear of this learning curve of this new approach, but again, as we'll discuss, the learning curve is not as challenging as it sounds. With respect to pain control, it was perceived that this biopsy needs to be done under sedation or general anesthesia. It is absolutely well tolerated under local anesthesia with some practice, and we'll reassure you about that shortly. And then urinary retention. There does appear to be a slightly higher risk of urinary retention with transperineal approach as opposed to transrectal, but again, the magnitude of this issue is not as bad as it sounds. So let's jump in. So the real problem with transrectal biopsy is sepsis, okay? The prevalence of resistant bacteria is growing, and up to 25% of men harbor resistant flora at the time of biopsy, okay? And post-biopsy sepsis rates are described, and the concerning thing is they're increasing over time. Similarly, post-biopsy hospitalization rates are increasing, okay? So several steps have been taken by the American Urologic Association and the urologic community in general. We talk about targeted prophylaxis, which requires a rectal swab prior to biopsy to assess for resistant flora, and then antibiotics are tailored accordingly. Alternatively, augmented prophylaxis, where we add additional stronger antibiotics to decrease the risk of infections, are also employed. Now, both of those approaches, escalate antibiotics and therefore further potentiate development of resistance. Now, the impact of these infectious complications is very big. So a cost of post-biopsy sepsis episode ranges from between $8,000 and $19,000 in the US and slightly less abroad. It results in a length of stay between 1 to 14 days, and up to 0.25% of patients will require ICU care during this bounce back. So we really want to try to avoid this at all costs. So Dr. Borghese and company did a systematic review in 2017 looking at transperineal, they looked at all different biopsy approaches, prostate biopsy, and they kind of tried to quantify it. And some aspects or side effects of the biopsy are hard to quantify just because the ranges reported are very wide. So it's tough to compare. Hematuria, for example, is all over the place. But rectal bleeding is clearly a non-issue in the transperineal biopsy group. Hemospermia, also hard to quantify and maybe a function of the number of cores taken. Urinary retention. Okay, urinary retention is recognized as being higher in the transperineal cohort, but even though they listed in a range between 1.7 and 11%, I think it tends to lean towards a lower number in most of the series that are published. With respect to infectious complications, clearly transrectal approach, the traditional approach, fares much more poorly with much higher infectious complication rates, and hospital readmissions tend to be higher after transrectal approach. So I want to look at several series. There are several large series that have been published, and I think they're very representative of what the complication profile is. So looking at the infectious complications, there is a this first series that I list is the Australian series. They had almost 1,400 transperineal biopsies, of whom 3/4 of the patients were only given 1 dose of cefazolin, and they report 0 readmissions for infectious complications. So that's obviously excellent outcome. Stefanova, this is the Toronto series. They also had approximately 1,300 patients. And again, they also use 1 dose cefuroxime or cephalexin. And they report 0.3% of infectious complications, which consisted of 3 UTIs, which were treated empirically, meaning no culture was available, and only 1 culture-proven UTI that was treated with antibiotics. And again, none of the patients require readmission. So also very low number of infectious complications. Ristal et al., that's a US series of approximately 1,000 transperineal cases. Initially, they started off giving 1 dose of cephalexin, and then they've later transitioned to omitting antibiotics altogether. So this is excellent antibiotic stewardship. And again, they also reported 0.3% infectious complications, none of which really were culture proven, but because they were treated with antibiotics, they had to be classified as such. And again, they also report no infectious readmissions. Pepe et al., that's an Italian series. They have a very large series of 3,000 cases, and at that time they use levofloxacin for 3 days, and they report a 2.4% UTI rate, and that's relatively high for most of the series that are published for transperineal biopsies. And they had also reported a 0.7% readmission rate for infectious complications. Okay, so with respect to the urinary retention rates, okay, the Australian experience lists 1.8% retention rate. Canadian experience, the Toronto series, 1.6%. The US experience, 0.1%, so not very much urinary retention. And the Pepe et al., the Italian experience, shows 6.8%, which is slightly higher than most other series that reported. And again, their retention rates varied with respect to number of cores taken and prostate size, with more cores resulting in more retention and larger prostates resulting in more retention. All right, how about cancer detection rates? Okay, cancer detection rates are obviously critical. We do not want to introduce a procedure that is inferior to what we currently have, because the goal of biopsy is diagnosing clinically significant prostate cancer. So, Ristal et al., they initially started off with a template that required 16 cores, and then ultimately adopted a template that sampled 10 sectors or 10 areas in the prostate, and their detection of any cancer type was overall 60%, although when they adopted the new template, it rose to 70%, 71%. And their clinically significant cancer, defined as greater than grade group 2, was 40%, which is also very good, and even higher for the newer template that they adopted. The Toronto series, they used a 10-core template, and again, their any cancer detection rate was 50%, with clinically significant prostate cancer detected in 30% of patients. Now, they compared themselves to their previous series of transrectal biopsies. So this is a direct comparison of transperineal versus transrectal, and they noted to have better overall cancer detection rate in the transperineal group as opposed to transrectal group. Importantly, they detected approximately 10% of cancers in the anterior segment of the prostate, which was exclusively anterior. There are many cancers that are present both posterior and anterior areas of the prostate, but there are some that are unique to being anterior, and these are the cancers that would have been missed using transrectal approach. So this is another advantage of transperineal approach. And then Omar et al. Did a literature review, and they listed series between 2014 and 2019. And again, their overall cancer detection rate varied, but was generally between 42% and in some series even 100%. And clinically significant prostate cancer was detected between 10 and 57%. And again, they confirmed the incidence of anterior cancers at about 9.5%. So again, this number keeps coming up. Approximately 10% of anterior cancers are detected with transperineal biopsy, and that's the cancers that would have been missed. So the cancer detection rates are adequate, and they're same or better than for transrectal approach. Some concerns about the learning curve. Those numbers are a little bit hard to come by, but in the Toronto series, they described gaining confidence in approximately 4 to 6 weeks of doing these biopsies, but that really didn't quantify the number of procedures performed. Dr. Wu et al. And Arvin George and company performed a survey of Michigan Urologic Regional Collaborative and Pennsylvania Urologic, Michigan Urologic Surgical Improvement Collaborative and Pennsylvania Urologic Regional Collaborative. These are quality improvement collaboratives. So they surveyed all the urologists that perform biopsies, and of those that perform transperineal biopsies, they asked what they felt was a fair number of cases before they felt comfortable doing this procedure, and the answer was approximately 10 cases or less. So that's encouraging. That's not a very large number of cases to be comfortable with this procedure. This is not very different from transrectal biopsy, which was reported at about 10 cases to gain confidence. So learning curve should not really be a prohibitive factor in adopting this approach. There are excellent resources online, and I would encourage everybody to go to Michigan Urologic Surgical Improvement Collaborative website, and they have a ton of resources ranging from checklists to templates to how-tos, and so there's a lot of support out there. So room setup. What do you need? You need a patient in lithotomy position. So this is how my room is set up. I have an ultrasound probe. I have more recently, I have a stretcher with stirrups attached to it, and I have a table with all my equipment. Previously, I used to do this biopsy on an exam table that rises and lowers that had stirrups built into it. But basically, any kind of bed or stretcher with stirrups would be sufficient. What probe do you use? There's a lot of probe designs out there. So you have an Enfire probe, for example. That's this probe in blue that scans through the prostate, and you know, that when the needle travels from the tip of the biopsy probe, that's how you visualize the needle. Then you have a biplanar or side-fire probe, which visualizes prostate. That would be this probe over here in sagittal and transverse planes, and this is ideal where the needle travels through the side of the probe as opposed to off the tip of the probe. And then you have this probe, which I think is the probe that's ideal for transperineal approach. This has a long linear array of sagittal beam, and then it has a transverse beam as well. So you can visualize the prostate in 2 dimensions by switching between the two. And what this long linear array does, it allows you to visualize the tissue between the skin and the prostate. So it allows you to visualize the perineal structures, and also it allows you to track your needle as it travels parallel the probe towards the prostate. Positioning. Okay, so patient is placed in the lithotomy position. In my practice, that's done by a nurse. Patient's scrotum is taped out of the way, and skin is prepped. I use betadine, but chlorhexidine prep would also be adequate. So when patients come, or when I counsel my patients about prostate biopsy, transperineal prostate biopsy, I say, it's like going to the dentist, because they're always concerned, this is going to be painful. And I say, it's like going to the dentist. It's going to be a little bit uncomfortable when I inject the numbing agent. And once that kicks in, you should be pretty good. And so I think the crux of transperineal biopsy is being able to, especially biopsy in the office, is being able to provide local analgesia. And in order to do that, we need to kind of better understand the anatomy and the innervation. So this is a male perineum. This is a pelvic plexus or a hypogastric plexus that supplies the innervation to the capsule of the prostate. Okay, this is the levator ani muscle, and this is the rhabdosphincter over here. And this is deep transverse muscles of the perineum, and then there's another set of superficial transverse muscles of the perineum. And again, the pudendal nerve and superficial and deep perineal nerves are the nerves that supply these structures over here. So we need to focus on being able to interrupt signaling from the pelvic plexus, the superficial and deep perineal nerves, or the pudendal nerve. So there's various approaches to transperineal anesthesia that are adopted or described. And This is a particularly good one that I find. So you need to obviously use a lot of lubricant because probe insertion and manipulation is uncomfortable. You anesthetize the skin for your needles to travel through, okay? And then it's basically prostate capsule, skin, and everything in between. Okay, so the prostate capsule, is supplied by the peripheral branches of the pelvic plexus. Okay, as I showed you in the previous picture. And then the in-between stuff, the levator ani and the bulbar cavernosus muscles are the ones that would cause a lot of pain when penetrated with a needle. They are fed by the pudendal nerve. And deep transverse perineal muscles is fed by the perineal nerve. And so, how do we anesthetize those locations? So this is a schematic proposed by Wang et al. And what they look at is placing the needle in a trajectory about 1.5 centimeters above and 2 centimeters lateral to the anus, and looking in sagittal plane. This is actually parasagittal. So this would be the levator muscle. This would be the apex of the prostate. So they would perform an injection where these black dots are, superficial to the levator muscle and deep to the levator muscle. And they found that to be an excellent way to anesthetize patient for in-office local analgesia. This is another article by Kuba, and that describes periapical triangle. So periapical triangle is a space that's lined by the apex of the prostate, rhabdosphincter, sphincter, and levator ani muscle. And this is a deep transverse perineal muscle with a rectum below. So they describe a trajectory where the needle would travel here, and they would inject the bolus in this periapical triangle. Additionally, so if you look at the prostate en face here, what you would see is, even though the periapical triangle is over here, sometimes if you need to reach the lateral or anterior part of the part of the prostate, you would need to travel through the levator ani. And so you would need to anesthetize additionally levator ani for the patient to tolerate those biopsies a little bit better. So again, this is kind of stepping through from midline to sagittal. So you would have the rhabdosphincter, the urethra, and the prostate, and you would step to the side, and you would see the DVC, and then further to the side, you would see the levator ani. So they would inject their points. Their injection points would be right here and right here. And I generally agree with that approach. I tend to inject my anesthetic a little bit higher, not quite at the base, but just maybe 0.5 centimeter above, and I injected anterior or superficial to and deep to the levator ani muscle, and I want to see it track superiorly, because that assures me that a wider field is affected, and I think you get excellent analgesia that way. Other sites that are described in the literature for local analgesia include the pelvic plexus block, which is at the tip of the seminal vesicles, or the periprostatic block, which is, you would traditionally, during transrectal biopsy, go transrectally and block in this area. And this would be the transperineal version of the same. So there's some comparisons in the literature on how well these blocks work. So they use visual analog scale to assess this. And again, there's different block types that have been compared, but you can see generally the visual analog scale doesn't really go beyond 3.5 too much. And this is for the periapical triangle, or perineal skin in the apex, or periprostatic nerve block. And you can see again, during the analgesia infiltration and during the actual procedure itself, the numbers pretty much stay below 3.6 looks like the highest, and that's for the visual analog scale. Now in the Toronto series, they actually looked at 500 patients, and again, they did them under local anesthesia, and they used skin and periprostatic block, and they compared various parts of the transperineal procedure. And again, the highest discomfort was at the time of skin infiltration, where you raise a wheel in order to be able to place your access needle. Then the next most uncomfortable aspect was the periprostatic infiltration, and then after that it was the actual biopsies themselves and the probe manipulation. Okay, access type. How do you get to the prostate? So you can have a grid. You can have a which means the needle travels through its individual separate puncture every time you're collecting a core of the prostate. Or you can have a trocar or an access needle that then allows you to pass the needle multiple times without penetrating the skin each time you pass the needle. So this is kind of a fan type, freehand fan type access, where the trocar would be positioned in one spot, and then you would simply angle the needle in order to sample the desired area of the prostate, and this would be just individual kind of punctures in the skin to get to the areas that you need. Let's see. Okay, so this is different access options. Okay, so you could have your stepper and the grid, and that's really more common to be done when patient is asleep in the operating room, and you can do that template mapping where you can have, you know, the segments could be, you know, as low as 5 millimeters apart, and you can really map out the prostate in 3 dimensions really well. But then again, would require sedation or general anesthesia. You could have this is called a precision point. This is probably the most widely used transperineal device, and what it does is it has a clip and a rail system that attaches on a ultrasound probe, and then it has a carriage with apertures that then penetrates the perineum and anchors it in place, and you can choose the depth of your needle, of how close you want to be to the ultrasound probe, or how far away, depending on where you want to sample the prostate. And what it does, what allows you to do is allows you to track the needle real time as you move your probe, so you don't have to keep looking for your needle, because, you know, the needle has to be in view ultrasound beam, and if you're doing it freehand and they're not aligned, it's a little bit challenging. So this solves that problem, and so that's a tool that could be used during freehand coaxial access. Other coaxial accesses are just simply, you know, needles, hollow needles through which you can insert the trocar. There are some, so precision point is a disposable device. There are some reusable devices that are out there, and what I typically use is I simply use an angiocatheter. It's a little bit more challenging, but once you get the hang of it, which is really not that hard, I think it's cost effective and very versatile. Okay, transperineal templates. It's a little bit of a wild west out there as far as the number of templates that different urologists use and that have been published in literature. But there are two kind of most common, I would say, that have emerged, and the two are the Ginzburg protocol, unrelated to, you know, my last name is Ginzburg, spelled differently, but this is the Ginzburg protocol that's been kind of developed by the UK and Australian guys, and what it does is it divides prostate into sectors. Okay, so just focusing on one side, let's say the left side, there's anterior sector, mid sector, and posterior sector. Okay, and in sagittal views, that's how it looks. The anterior sector measures samples this area, mid sector this area, and posterior sector is down below. And if the prostate is greater than, let's say, 30 cc's, then you may have to add a basal sector to make sure you comprehensively sample the prostate. And each sector collects 4 cores, and some biopsy templates divide sectors into the medial sector or the lateral sector, so the number of cores ranges depending on the prostate size. The alternative to this template is the modified Barzell template, which is, this is from the Michigan Urologic Surgical Improvement Collaborative Group, but it basically has 12 cores or 12 areas that need to be biopsied. And again, it focuses on the transition zone just to pretty much sample it. And then, preferentially it collects samples from the peripheral zone, which is where most cancers are located. And it also incorporates the lateral horns, which I think are really important to biopsy. This is the template that I use. I like to simplify it. I simplified it, and this is the FAT template, the Philadelphia Hybrid Anatomic Transperineal template. But basically, it only has 8 sectors. At the apex, it has 4 sectors, anterior and posterior on each side. And at the base, it has 4 sectors, anterior and posterior on each side. And I take several cores from each sector, 2 from the anterior sectors and 3 from the posterior sectors. Obviously, if prostate is really big, I may increase that number of cores. But on average, I collect 12 cores from my FAT template. So what's required for the actual biopsy? So I don't bowel prep my patients. I use either betadine or you can use chlorhexidine prep to cleanse the perineum. You have several syringes of 1% lidocaine. You have a 23 gauge needle, and that's to anesthetize the skin. You have a 14 gauge needle, and that's my trocar or my angiocath that I use for access to the perineum. You have a 5-inch spinal needle that then allows you to deliver anesthetic deeper. And then I use a 18 gauge, 20 centimeter biopsy gun. These guns come in different lengths. I think the shorter the length actually is easier to maneuver. It's stiffer, so it's easier to angle towards the desired location. Then you have you need the silk tape to tape the scrotum out of the way. So I have a short video that I wanted to show. Doesn't let me pause it. That doesn't look like. Okay, so we'll watch the video and then I'll try to pause it if I can. So patients in lithotomy position, we have a probe insertion, and this is what you visualize on the screen as you insert the probe. So let me see if it let me pause now. Great. So prostate, rectum, this would be the apex of the prostate. Oop. I apologize for this, guys. So urethra. So this is me injecting local anesthetic into the skin, raising a wheel in order to numb up a small area for the trocar placement. I also injected further in to anesthetize the tract. So then I use my 14 gauge angiocath to place inside the perineum to give me access into the perineum. Now, it's really important to be orthogonal and aligned with your probe as you're placing this trocars, because if they're angled, then you'll have a hard time finding your biopsy needle during the procedure itself. So they really have to be orthogonal right along the side of the probe. This is the 25 gauge spinal needle for the local analgesia. And again, we're going to use the periapical triangle type, slightly modified because I go just a teeny bit lateral to that. So again, prostate, this dark structure is the levator ani muscle. And you puff some analgesia, some lidocaine as you advance the needle. Then you inject superficial to levator. And then you inject deep to And as you see, I'm constantly scanning through to visualize my needle. And you can see the anesthetic tracking superiorly, therefore blocking the entire surface of the prostate. And that's it. That's the extent of local anesthetic. And we do the same thing on the other side. So levator ani, just anterior to levator ani, or just superficial, and then just deep, and you can see that tracking. And again, it's just at the medial aspect of levator ani. And this is my biopsy gun. Biopsy, and again, we use the FAT template like I described earlier. So here we're sampling the anterior aspect of the prostate. So that was the transition zone. And then we insert the needle again. And again, it's a relatively dynamic exercise. I scan through my needle. This is the lateral anterior sample. And then we go anterior, but base, towards the base. And then at the base, but more laterally. Now we're gonna focus on the posterior apical zone. And you can really see the degrees of freedom that you have available. You can angle the needle down, and you really want to sample in this area. And you can see the needle trajectory collecting a full core. Whereas if we were doing this transrectally, going in this direction, only part of the core would be involved with the peripheral zone. So, and then at the end, you know, we have individual samples that, or individual sectors that are submitted. Okay, great. Ooh. So, and then once you master that approach, there are other things you can do. So by kind of being able to do transperineal biopsy, you're also able to place transperineal fiducial markers for patients that are undergoing radiation therapy. And spacer hydrogel product is also injected transperineally. And again, it's just a natural extension of your skill set once you know how to do transperineal biopsy, to be able to inject the hydrogel. And that's to improve or to decrease rectal toxicity at the time of radiation treatments for prostate cancer. So, you know, sometimes it could be a little bit intimidating because it's perceived that new equipment is required, but many times this equipment already exists in our institution. So ask the question, do you guys have a brachytherapy program at your institution, or did you at one point? And if yes, then chances are you have a biplanar probe, an endocavity probe with a linear side-fire array, which is the ideal probe for transperineal biopsy. And likely you have a stepper. So borrow it for your radiation oncology colleagues and give it a try. So, and then again, you can do both transperineal biopsy, fiducial markers, and spacer hydrogel through the transperineal approach. This picture is of the ultrasound that I started with. I borrowed it from my radiation oncology colleagues, and then when it died, then I upgraded to the newer ultrasound that I have. But, you know, the equipment may very well be there already. Just ask around. So I just wanted to share kind of our Einstein series. This is not a published series, but we started late 2017. We currently have about 180 patients. The median age of our biopsies is age of 63, PSA 6.2. And again, we use we kind of went through several permutations of templates, but ultimately settled on this FAT template, which has 8 sectors. And on average, we collect between 16 and 24 cores per biopsy. So over 77% of my biopsies are done in the office. I pretty much exclusively do transperineal biopsies now. And less than a quarter are done in the OR, and that's really the patient request. Most of my biopsies are done for diagnostic purposes, and about 16% are done for active surveillance. I have stopped giving antibiotics, so 85% of my patients received no antibiotics at all, 0. Okay, and earlier on I gave some antibiotics when our protocol was to give IM Rocephin ×1. So cancer detection rates. So cancer detection rates are really hard to compare because you really can't really compare them without controlling for different variables. So basically, if I just look at the biopsy naive patients, so I exclude active surveillance, I exclude patients with prior negative biopsy. So this is just biopsy naive patients and just the ones I do in an office, okay, not in the OR, under local anesthesia. My overall cancer detection rate is 73%, which I think is pretty good. And my clinically significant cancer detection rate is 49%, okay? And so I think that compares well with other transperineal series and is superior to the transrectal approach. With respect to the complications, I think this is really important. I track my complications closely, and of all the patients that I've done, I had 2 patients that had syncope. One had syncope hours after the procedure, one had syncope immediately after the procedure. So 2 syncopes. I had 1 patient that could not tolerate transperineal procedure, but I then offered that patient transrectal procedure and he couldn't tolerate that either. So we ended up doing him in the operating room. I had 1 patient that had hematuria with clot retention. That was within my first 10 biopsies that I've done transperineally, and he did require admission and Hind irrigation. But that's the only hematuria requiring an intervention that I had. And I had one patient that had dysuria, and we treated him with antibiotics. Dysuria went away, but he had a culture prior to antibiotics, which was negative. But because he improved with antibiotics, we presume it's infectious. So 1 patient out of 178 that had a UTI-like scenario. So overall, I think the outcomes, cancer control, cancer detection rate, complications, and ability to avoid antibiotics are really attractive for this approach. So in summary, this can be done in the office. It can be very well tolerated. Cancer detection rate is on par or most commonly better than transrectal approach. You get unique access to the anterior prostate, and you have unique access to the apex. You practice excellent antibiotic stewardship because you can definitely omit antibiotics for most of these procedures. There are no sepsis or very low amount of sepsis reported for this approach. Rectal bleeding is a non-issue. And there are multiple access techniques so you can find which works best for you. And most importantly, all the cool kids are doing it. And here's some COVID humor for you, since we're on quarantine and we don't travel anymore. I will ask you to scan this slide and give your feedback on how you like the presentation so that UCSF can continue to improve their series. And I will take any questions. I'll unshare my screen.
So thanks very much, Dr. Ginzburg. I think we do have some time for a couple of questions. One that came up was with regards to when you're performing these either in the office or the OR, do you generally prefer to do these free-handed using a stepper? Do you sometimes feel that sometimes the stepper may limit your mobility? And do you think that one's easier to learn than the other?
So I think, excellent question. And I perform all my biopsy freehand just because I like to have the degrees of freedom, and I find the stepper somewhat cumbersome. Is it easier to learn with the stepper? Not necessarily. I think what makes it easier to learn is this precision point system that can attach to your biopsy probe. And what it does is it allows you to visualize the needle as you biopsy at all times, and it eliminates the variable where you have to scan sagittally to find your needle. So I mean, once you gain enough experience, you can pretty much always find your needle. But I think when you're initially starting out, this could be a little frustrating. So I do prefer freehand. I am not a fan of the stepper, but stepper is appropriate in some situations, and obviously stepper is used for spacer hydrogel injection. So you should be familiar with how to use that. Thank you.
Thanks, yeah, very much. And then just one more was kind of with regard to fusion biopsies. Are you performing, fusion biopsies Obviously, with this, it'd most likely be, you know, cognitive, but are there other types of biopsies available or fusion biopsies, and are you using them?
There are a lot of technologies out there that are making themselves compatible with transperineal approach. Obviously, fusion biopsy technologies emerged at the height of transrectal biopsy era, if you will. So a lot of them are paired with transrectal probe techniques, but many of them are converting and restructuring to be applied transperineally as well. And I have a transrectal fusion system, which I use rarely, but what I do is I do cognitive fusion transperineally. And I think what I find is cognitive fusion transperineally is more intuitive because it's symmetric, patient is in lithotomy position, and the images of the MRI naturally translate to the lithotomy transperineal approach. So I do cognitive fusion, but there's a lot of technology for true fusion to be done transperineally.
And then I think just one final one that just kind of came in here was comparing, you know, your transrectal to your transperineal experience. How do you find that patients tolerate one versus the other in the office? Is it similar?
I really think it's similar and possibly even better because I have, you know, a lot of areas where I can inject the anesthetic transperineally. Transrectally, I typically go through the rectum and I inject it, you know, like at the base of the prostate, between the prostate and the sem. But transperineally, you know, I can really thoroughly anesthetize it. And the most discomfort, almost all the series report that the most discomfort is experienced when the anesthetic is injected. So if you prepare the patient adequately and you explain to them, you know, this is going to be a pinch and a burn, it's going to hurt a little bit, but once it kicks in, you're going to be great. I think the patient expectations are set, and I think they do really well. So in my experience, I think they tolerate it similarly, if not better, for the transperineal approach.
Awesome. Well, thank you so much for this talk, and I guess I'll thank you, CSF, and kick it back to you as well.
Thank you, Christy.